Okay, let's start. Welcome to the Step 2 CK OBGYN. So now, if you are a 30-year-old female who's pregnant at 41-week gestation, and then I do the fetal heart monitoring, I find variable deceleration. What do you think is causing that?
Um, okay. Variable deceleration. I know that cord compression can cause
Excellent.
that.
Yeah, it's umbilical cord compression. Early deceleration is fetal head compression and can be normal fetal heart racing in early. Late deceleration, you know that, placental insufficiency. But variable cord compression could be oligohydramnion and cord prolapse. All of those cause variable deceleration. Okay? Okay, so let's continue. So if you are a 25-year-old female who present to the prenatal visit and you had a cervical loop electrosurgical excision 8 months ago for severe cervical dysplasia. Last menstrual period was 16 weeks ago. What do you think are the complications of that? Okay, so if you are a 25-year-old female who had a cervical cancer, I did loop on you, leap cervical loop extra leap procedure. What are the complications for this
Mhm.
procedure?
Cervical insufficiency and cervical stenosis.
Yeah, excellent. So this is the cervical insufficiency. One of the risk factor are leap. The other risk factor for cervical insufficiency. What are the other risk factor?
Cervical
Yeah, cervical stenosis. What are the other risk factors? They love these risk factors.
Oh, okay.
What is it? Hmm?
Those are the two,
Ob-
of course, if you're pregnant preterm.
Obstetrical trauma, multiple gestation, Malarian anomalies, history of preterm birth, or second trimester pregnancy loss.
Second trimester pregnancy. You say Mullerian?
Yeah, Malarian anomalies, history of
How?
preterm, huh? Yeah, like if you have two uterus or the split septum in the uterus and stuff like that, you're high risk of losing babies.
Dr. Ali, you're going in and out. I don't know what is going on with.
Hello? What's going on? Let me see. So just let me summarize this question before we go to the next one. So this about risk factor for cervical insufficiency. They love these risk factors, okay, and they leave you confused. So it's trauma, multiple gestation, Mullerian anomalies, history of preterm, and second trimester pregnancy loss, and leap procedure. All of those are risk factor for cervical insufficiency. Okay. Okay.
All right.
So So patient who have the placenta cover the internal cervical os, what do you counsel her on?
So no sexual activity
Yeah, excellent. Yeah.
and
So yeah,
yeah.
perfect. Yeah. So if you are a 39-year-old female who have 10-week gestation uterus and discomfort with uterine manipulation, I check your AST ALT around 40. Okay. And now you presented with nausea, vomiting, that worsening progressively, and you lost 8 pounds in the pregnancy. Like you're supposed to gain 1 pound in pregnancy. That's the only time you're happy you're gaining pounds. But now you're losing pounds even in pregnancy, and you have intermittent vaginal bleeding, dry mucosa. What do you think is going on? Ketone in the urine. That's
What?
You have ketone in the urine. That's the biggest clue too.
Oh, ketone in the urine.
Hmm?
Is it hyperemesis gravitorum?
Perfect. So what test do you order?
What test do you order?
Hmm?
Let's see. So it can be due to multiple gestation. It can be due to
Excellent. So we order
moles.
we
Yeah.
order pelvic ultrasound. So because the risk factor hyperemesis gravidarum in a prior pregnancy, that's a risk factor. Multiple gestation, gestational trophoblastic disease, those are
Smaller
risk
pregnancy.
factors.
Yeah.
Yeah. Clinical feature, they have severe persistent vomiting, fluid electrolyte abnormalities, ketonuria, more than 5% loss of pre-pregnancy weight. Okay, in the workup you have orthostatic vital signs.
Mm-hmm.
You check the serum electrolytes, blood urea, nitrogen, and creatinine. You check the thyroid function test and urinalysis.
Mm-hmm.
How do you treat that?
How do you or you give them IV fluid if there are signs of dehydration, and you can also give them antiemetics for nausea.
Yeah, dietary modification and hydration. That's how you do. Okay, so if you are a 32-year-old female at a 30-week gestation, you came to me with a painful contraction. Okay, cervical dilation, 80% effaced, 3 cm dilated, and I do the fetal heart monitoring. I found that contraction every 7 minutes. So it's a preterm labor. You coming to me in a preterm labor. Okay, I gave you tocolytics and steroid. What should I give you? What else should I give you? Hello? Hello? So, so if you are a 32-year-old woman at a 30-week gestation presented with a preterm labor, I gave you tocolytic and steroid. What else should I give you now? Okay, so this is very important question and high yield and coming up in the exam all the time. So if you are a
Okay.
32-year-old female at a 30-week gestation who presented with a preterm, I gave you tocolytic and steroid. What else should I give?
I said give a prophylaxis for GBS.
There's very important thing. Whenever you have preterm labor, less than 32, or you give magnesium sulfate. That's very important for neural development.
Mm-hmm.
Okay, so this is how you work up for a preterm delivery. If you have a girl with a preterm less than 34-week gestation, you look at the contraction. Is it a regular contraction, which means 4 in 20 minutes or 8 in 60 minutes, and cervical dilation or effacement, plus no indication for delivery. If you have all of these three, then you give tocolysis, steroid for lung maturity, and magnesium sulfate for neuroprotection if it's less than 32 week. Okay, if there is none of that, if the contraction is not 4 every 20 minutes, 8 in 60 minutes, sometimes they confuse you with that, so you gotta pay attention to how many contractions. So in this case, no treatment indicated. You just consider ultrasound for cervical length, fetal fibronectin to assess for preterm birth risk. Okay?
Mm-hmm.
Yes, and that's the workup for a preterm birth.
Okay, so what if she's having a regular contraction, and you've given the tocolytics and given the MAC sulfate and steroid? What about the GBS prophylaxis? You don't do that now, or?
That depends. If she has positive GPS, she has rupture of membrane more than 18 hour, then
I thought they said because the pregnancy has not progressed to 35, 37 weeks, you can just go ahead and give it, because, if the patient is about to deliver, you should give the GBS prophylaxis.
yeah, you can give her if the GPS status unknown and stuff.
Mm-hmm.
Yeah, you can give her for sure.
Okay.
Okay, so if you are a 32-year-old woman who presented with a painful contraction as she transitioned into labor, but now I gave you epidural anesthesia. When I give you epidural anesthesia, immediately after you felt lightheadedness and a blood pressure 90/55. Why?
I think they said it has something to do with the epidural. I don't know if leak or something like that.
Yeah, vasodilation and venous pooling. that can happen when you do epidural anesthesia. That's one of the complications. So you gotta be aware of that. Okay, so if you are a 28-year-old female at a 41-week gestation, what are you at risk for complication of this post-term pregnancy?
So this is post-term.
Yeah, she's scheduled to be for labor at 42 week. What's complications for that?
So there is gonna be maybe what do you call it? Macrosomia, because the baby is gonna be like bigger. There can also be like fetal death. There is also like oligo. Those are the three that I'm on top
Yeah,
of my head.
yeah, the fetal,
Macrosomia,
yeah,
oligo, fetal death.
yeah,
What
perfect.
else?
Fetal, they have oligohydramnion, meconium aspiration,
Okay.
stillbirth, macrosomia, and convulsion. The
Convulsion. Okay.
maternal complication, they have postpartum hemorrhage, perinatal trauma, perineal trauma, and postpartum hemorrhage, infection, and C-section.
That's fix. C-section. Okay.
Okay, so this is an easy one. So if you are a 22-year-old female at 10-week gestation who presented with vaginal bleeding, I check your cervix, I find it closed, and the ultrasound shows vacant uterine cavity and free adnexa. Beta Hcg is positive. What type of abortion is that?
You said it's easy one. Okay. Say it one more time. Okay. So
The
the
uterus,
cervix
so the
closed.
cervix is closed and the uterus is empty, and you found, so she did not, she had some crampy pain that did not subside only after a blood covered white mass passed through her vagina a few minutes later, and you did the uterus, you find it empty. So even if I don't give you the white mass that passed, if I tell you cervix is
Complete.
closed, yeah, perfect, complete abortion. Yeah. Because cervix closed and empty uterus, complete, period. That's it.
Right.
So if you are a 23-year-old female present with abdominal pain, vaginal spotting, on physical exam I found right adnexal tenderness. What's best next step?
Pregnancy test.
Yeah, after that, pregnancy is positive. Yeah.
So is it ultrasound?
Yeah, transvaginal ultrasound. Yeah, perfect.
Transvaginal ultrasound, yeah.
Okay, so if you are 26-year-old female who have swelling hands and feet, creatinine is 2.1, and ANA is positive in high titer. What do you think is your diagnosis?
The ANA is positive. Is it lupus?
Yeah, lupus. They have
Nephritis?
glomerulonephritis. Yeah.
Mm-hmm.
So if you are a 2-hour-old African American boy who evaluated for minimal right arm movement, when I examined you, I found a small area of edema in the scalp above the periosteum, and the right upper extremity is held in adduction, internal rotation, with the elbow extended, forearm pronated, wrist and fingers flexed. So how do you treat that?
Okay. So I think let me see the diagnosis first. Duchenne. Yeah, Duchenne palsy. And I think they said you pin the arm to the baby's clothing, and then it's gonna heal spontaneously, like in the next few weeks, 2 to 3 weeks, something like that.
Yeah, reassure. So what are the risk
Reassurance.
factors for fetal macrosomia? These risk factors are, I think it's annoying, and they ask about it. At least for me, like I don't know, like sometimes they are similar. So what are the risk factors for fetal macrosomia?
Of course, gestational diabetes.
Yeah, what else?
I say, yeah, what else? um,
So, advanced age, diabetes,
Yeah.
excessive
Okay.
weight during pregnancy or
Excessive
pre-existing
weight.
obesity, multiparity, and the
Mm-hmm.
fetal risk factor African American and Hispanic, male sex, and postpartum pregnancy.
Mm. Okay.
What are the contraindications to breastfeeding?
Contraindication to breastfeeding will be one is I think HIV in US will be, but not, like in the developing country. If they have a hepatic lesion on the breast, if they are taking a TB medication less than, I think, is it less than 2 weeks or less than 2 months, they're on TB medication. If they are taking like what do you call it, substance, like alcohol and drugs, if they are still using alcohol and drugs. I think there is one more. Then something about varicella, 5 days, 2 days, something. I think 5 days before, 2 days post-op or something like that.
Yeah, so the contraindication to breastfeeding
Mm-hmm.
I divided into infection and drugs. Infection,
Okay.
TB,
Mm-hmm.
HIV,
Mm-hmm.
herpetic breast region,
Mm-hmm.
varicella infection less than 5 days before or two
Less than
days
five
after
days. Okay.
delivery. Okay.
5, 2. Okay.
Drugs, substance abuse, alcohol, drugs,
Mm-hmm.
chemotherapy, or ongoing radiation.
Chemotherapy. Okay, let me say it again. So infections, HIV, TB, hepatic lesions, varicella, 5 days before, 2 days post-op. Then you said chemicals like drugs.
Yeah,
Okay.
drugs, alcohol, chemotherapy, and anti-TB is not a contraindication. Only contraindication for the first 2 weeks, but after that you can do breastfeeding.
First 2 weeks, yeah.
Yeah.
Okay.
And the infant risk factors, which one? The contraindication?
Oh, galactosemia.
Perfect, yeah, galactose.
Mhm.
So pregnant have bilateral pitting edema of the calves, ankle, and feet. What is that? That's
The
normal in
what?
a pregnancy. If you have pitting edema in a pregnancy, that's normal,
Mm-hmm.
reassure.
Mm-hmm. Okay.
Okay, now if you are a 78-year-old woman who presents with urinary incontinence, okay, and on physical exam you have thin, pale vaginal mucosa, what's best next step to evaluate that urinary incontinence?
Oh, okay. This sounds more like atrophic vaginitis.
Yeah.
Okay.
So
What
what's
is the next
best step to evaluate incontinence?
evaluating continence in atrophic vaginitis? No, maybe you
You
want
do.
to rule out all the other ones.
Yeah, you do urinalysis. That's how to begin with,
Okay.
because
Okay.
the incontinence it could be caused by
Alright.
genitourinary infection, which is urethral
Mm-hmm.
sphincter, pelvic floor weakness, urogenital fistula. It could be neurologic, which is
Mm-hmm.
multiple
Mm-hmm.
sclerosis, dementia, spinal
I'm
cord
sorry.
lesion.
And where are you calling from?
Hmm? What is it? Hello?
It's not me.
Oh, okay. And there are reversible causes, which is delirium, infection, atrophic urethritis, okay, or pharmacological like alpha blocker,
Mm-hmm.
diuretics, psychological like
Diaper. Okay.
depression can cause urinary incontinence. Can you imagine?
Mm-hmm.
Excess urine output, diabetes, CHF, restricted mobility post surgery, stool impaction. Okay, this can cause that. So, how to manage bacteria in a pregnant female?
Okay. So bacteria in a pregnant female. Of course,
Bacteriuria,
if
yeah.
bacteria, you always treat. You're gonna treat because you want to prevent like a pilo. So what you're gonna do is to give. Oh. You can do the cephalosporin, which what do you call it? Ceftriaxone. You can do, let's say, Bactrim. I think you can do Bactrim only in the second trimester, not in the first and the third trimester. You don't do fluoroquinolones, and that's what I know. You have to treat, and then if it's yeah, I don't know what else. So asymptomatic bacteriuria, you have to treat it, and these are the medications you use. And then I think you do a clean catch, right? To do a test of cure, something like that.
Okay. Okay. So now,
Mm-hmm,
now is very important case. So if you are a
mm-hmm,
23-year-old female at
mm-hmm,
23-week gestation, you have
mm-hmm,
dry cough, dyspnea, inability to lie flat, and you have exercise intolerance, tiredness. If you're 23 and having all of these heart failure symptoms, that's scary. Your medical history is significant for recurrent sore throat that requiring tonsillectomy. Boom, that's a big clue. You immigrated from India. Boom, that's another clue. EKG shows atrial fibrillation. Wow, now it's the, the biggest clue. So what's your
mm-hmm.
diagnosis?
Mitral stenosis.
Perfect, yeah, mitral stenosis. Yeah, like that was a good question and stuff.
Mm-hmm.
Okay, so if you are a 53-year-old obese menopausal woman, okay, you have mild postmenopausal transition, mild hot, you don't have hot flashes or all of these things, and you know no vaginal dryness or dyspareunia. Why do you think that?
53-year-old.
Yeah, and you don't have, you don't, your menopause is not as bad as your friends, so you came to me asking me why my friends are all suffering from menopause but I'm not. Why? And this girl is obese.
Oh, okay, because she has what do you call it? The peripheral estrogen from the fat.
Yeah, yeah, and adrenal
Yeah.
androgen to estrogen by adipose tissue. Yeah, yeah.
Mm-hmm.
So what? How to work up secondary amenorrhea? The first thing,
Oh,
which is no menses more than 6 months. You know that. So what? How do you do? What's first thing?
so you do a pregnancy test first.
Okay, perfect. That's negative. What else?
Uh-huh. So if you do pregnancy test and then you do um don't tell me that's not the one you do transvaginal ultrasound. What is it that you do again? I know you do TSH and you do prolactin, but I think there's something you do before these ones.
Yeah, you ask her. Did you have any prior surgery? If she had a prior surgery, you do hysteroscopy. If
Okay.
no prior surgery, then you do prolactin, TSH,
Yes.
FSH.
Mm-hmm. Mm-hmm.
Okay? If the FSH high, this is premature ovarian failure. If the
Right.
TSH high, hypothyroidism. If the
Mm-hmm.
prolactin high, what do you do?
So if the prolactin is high, you don't really you treat. You
You do
do
brain MRI.
treatment. I thought you do treatment before you do the imaging. I don't know.
No,
Do
no,
you
it
do brain?
depends on the prolactin level. If it's more than 200,
Oh,
yeah.
okay.
And they advise to do MRI always, like just to see what's going on, you know.
I'm
How do
I'm
you treat it?
confused. Some
How,
things they
huh?
will tell you, oh,
Because how do you treat
manage.
it? Like if their prolactin is high, how do you treat it? If there is a tumor in the brain, so you gotta do
Uh-huh.
MRI. You gotta do MRI. You see what's going on in there.
Oh, really?
Yeah. So what are the benefits and risks of combined hormonal contraceptive?
Okay.
Yeah. What do you think?
The benefits, of course, for you want to use it if you want to what do you call it? One to against a pregnancy to prevent pregnancy.
Yeah.
And then secondly, you can also use it for treatment for things like endometriosis, like to normalize, what do you call it, menstrual period, right?
Yeah. And what cancer does it decrease risk for?
Okay, it decreases the risk of ovarian and endometrial cancer, increases cervical cancer.
Yeah, and decrease risk of benign breast disease too.
Right.
Yeah, the risk is cause thrombi, hypertension, hepatic adenoma, and can
Oh,
cause
okay, all those ones. Okay.
and rarely can cause stroke and MI.
And DVT too.
Yeah, exactly. Yeah,
Stroke. Yeah.
yeah,
Stroke, MI,
yeah.
DVT. Okay.
Now we'll come back to the obesity. Okay, so if you have a 33-year-old girl who's obese, morbidly obese, like the weight is 260 pound, you check the FSH/LH is normal, but she's having amenorrhea for the past 9 months. What's causing that? Obesity plus amenorrhea.
Estrogen, exposure to estrogen. Is that what it? Elevated estrogen.
Yeah, but what is the real reason? What's going on there?
Mm.
So that's the thing. That's a very interesting, and they not many questions they can get you. This question is called obesity hype and
Okay.
ovulation syndrome.
Mhm.
So what happened with that when someone is obese, have morbidly obesity, there will be an ovulation. Okay, the
Mhm.
FSH/LH will be normal, but the ovary is still producing estrogen, but progesterone is not being produced at the normal post-ovulation level. Therefore, progesterone withdrawal menses at the end of the cycle doesn't happen.
Mm.
Okay, so because of this obesity, you will have this anovulation.
So you say progesterone is not being produced?
Yeah, that's why you don't have menses.
Mhm.
Okay,
Okay.
so that's about it. Let's see. So if you were to, so if there's a 22-year-old female,
Mhm.
uh, this is her first sexual partner, and she's having pain during sexual activity, tense perineal musculature. How do you treat that?
She's having pain with
With sex?
sexual
Yeah,
intercourse.
yeah.
I think I remember this question.
Hmm?
So what you do is this the one you do CBT? There's really not much you can do. It's just I don't think there's any big treatment. You have to
Yeah.
do like is it a CBT
Yes.
therapy or something like that?
Yeah. So this is very interesting.
Uh-huh.
Condition happen in girls with their first sexual encounter in religious upbringings, and the one who
Oh,
have a
okay.
traumatic childhood
Hold on.
experience.
Is this the one you do dilation?
Yeah.
Yeah,
So
I
you do
think this is the one you
relaxation,
do
Kegel.
dilation.
Yeah,
Yeah.
relaxation, Kegel exercise, dilator, fingers.
Mhm.
Okay, just to bring desensitization.
Sure, sure. And then there is another one that is called, is it allodynia? The one that has to do with light touch, like when you try to
Vulvodynia. Yeah.
vulvodynia. Okay, this is the one you do the cognition, what
Yeah.
do you call behavioral therapy? Okay,
Yeah.
okay,
How do you
all right.
differentiate vaginal discharge, pathologic from physiologic?
Vaginal discharge.
Yeah. Hello.
Hello?
Hello. Yeah. Yeah. I can hear you. Yeah. What is it? Go ahead.
No, there is the regular vaginal discharge that is kind of like is it it's not like is stringy and odorless. I think odorless would be the key. It doesn't smell.
Yeah. So the physiologic is no odor,
Uh-huh.
negative vaginal
Mm-hmm.
exam,
Mm-hmm.
white, yellow in appearance, copious. That's how they
Right.
describe it. The pathologic is pruritus, burning,
Mm-hmm.
malodorous erythema, edema,
Mm-hmm.
friable vaginal mucosa, tender cervix. You may have
Ooh.
green or curd-like vaginal discharge. That's it. Okay. So if you are a 27-year-old female with hair on the upper lip and obesity and infertility, so how can I treat your infertility?
Clomiphene.
Perfect. Yeah, clomiphene straight. Yeah. Good job. Okay, so if you are an 18-year-old college student uh, who came for emergency contraception, what should I give you? Most effective one.
A, a copper IUD.
Yeah, perfect. Copper IUD. We don't give. What if I tell you this girl she has friable cervix? What do you give?
Then you do the other one. Is it Ulipristol?
Perfect. Good job. Yeah. So good job. So if you are a 47-year-old woman at 30, so this 47, and you had bilateral BSO, bilateral salpingo-oophorectomy, and leiomyoma uteri. Okay. So what is the most protective factor for ovarian cancer? That's a stupid question. Like they say, what is the protective? It's bilateral salpingo-oophorectomy. Obviously, like if you took them out, you're not gonna have ovarian cancer if you don't have ovaries, right?
Mm-hmm.
Yeah, so that's like a stupid question. I don't know why did they put it. Yeah. So what are the cancer risks, ovarian cancer risk?
Ovarian cancer risk will be, I think, nulliparity, something like that. You've never had a child, right? And so also, if I think, is it anovulation also is part of the risk factor? If
Yeah,
you're not ovulating all the time.
yeah, you don't have this risk factor, so that's good. Yeah,
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 those two are the ones, that has to do with ovary because what do you call it? Nulliparity, you've never had a child. Then anovulation, if you're not ovulating every month or every time,
yeah. So this there are
you're not,
genetic risk
I don't
fact.
know.
Yeah, there are genetic, which is BRCA1,
Oh,
BRCA
the
two.
genetic one, okay, BRC one,
Yeah,
and then the Lynch syndrome also,
yeah.
Lynch syndrome.
Ashkenazi Jewish to ancestry,
Okay,
autosomal
okay,
dominant sometimes. And the other risk factor is the premenopausal epithelial ovarian cancer, fallopian tube cancer, peritoneal cancer can
fallopian
have.
tube,
Breast cancer at age less than 50 can cause breast
breast
cancer in
cancer.
males, these genetics and stuff. So how do you do modify your risk for cancer?
How do you modify?
Yeah. So this is the modification. How do you decrease your risk? This one that we can choose. Bilateral salpingo or oophorectomy, that's number one. Second thing, oral contraceptive use. Third thing, if you have a child at age less than 30 years old, first live born, decrease
Mm-hmm,
your risk.
mm-hmm,
Breastfeeding and tubal ligation.
mm, okay.
So if you do all of those, you're at decreased risk factor for breast cancer. So how do you screen for cervical cancer?
Oh, so for cervical cancer, first of all, you start at age 21, and then age 21
How
to
about how
29.
about if you
Is
have
that what you're asking me?
how about if you have SLE?
SLE. Okay, SLE will be part of the immune deficiency, right? Or HIV. You start like at the time of diagnosis, and then you do another one at 6 months up until 2 years or something like that. And then now you do it.
Smart, good job. Yeah, yeah, and then annually after that. So after 6 months,
Right. Mm-hmm.
for 2 years, and then every year afterward.
Right.
Yeah. Well, other than that, you just every 3 years, or if you want to add HPV, then it's gonna be every 5 years.
Hmm. I think they said from 21 to 29 every 3 years. Then from 30 to 65, then you can do every 3 years or every 5 years with HPV testing.
Wow, look at you. I like how detailed you are. That's good.
Some things just
Smart,
stick, some
smart.
things don't
Yeah,
stick.
you're gonna do great on the exam, you know. You're gonna do well.
Amen. Amen.
I should give you the score report right now. This is
Thank you.
260. Yeah.
Amen. I claim it.
Yeah, yeah. So if you are a 76-year-old woman, on examination, the vulvar skin is thin, dry, white in color. Labia majora are difficult to visualize. What should I do right now?
Okay, so I am thinking this is Likens sclerosis.
Perfect. Yeah, do biopsy.
So you do, yeah, biopsy, and then you can do the steroid clobetasol, right? Cream.
Yeah, exactly. Yeah. So how do you work up primary infertility in less than 35 years old?
Oh,
Uh-huh.
oh my. Okay, let's see. Let's try. So primary infertility in less than 35 years old. So you're gonna start with the man first, right? Doing the semen analysis for the man, and then for the woman, you're gonna, of course, rule out pregnancy, and then do the what do you call it? The hysterosapinogram, looking at the tubes, right?
Right, yeah. Good job.
And then after that, then if it's fine, if it's normal, then you're gonna have to do the hormones, check for the hormones imbalance, FSH, LH, and things like that. And also do the ultrasound to check for the if there's any structural abnormalities. And that's all I know.
Perfect, yeah. So how do you treat, what's the role of HCG in a pregnancy?
The role
Yeah?
of SCG.
Yeah. To preserve corpus luteum. That's just a
Okay. Okay.
memorization. That's it. Yeah, so if someone breastfeeding,
Mm-hmm.
okay, so what contraception do you advise the patient?
Okay. If you're breastfeeding, I think I'm trying to remember the age,
Yeah, that's an
the
annoying
weeks.
question.
If they are is it less than 2 or 3 weeks, you don't give them anything with estrogen. You give them progesterone, contraceptive. So basically exclusive breastfeeding is not going to do it. So you have to give them progesterone, contraceptive. If they are less than, I remember the cutoff for the weeks, either 6 weeks or I don't. Do you remember? Then after that,
Yes.
they can be like on OCP.
Yeah,
Do you
smart.
remember the
Yeah.
cutoff weeks? I don't remember.
Yeah, I don't remember the cutoff weeks too.
Yeah.
Yeah. So you
So
just give them. So there are you have the options like progesterone only contraceptive,
mm-hmm,
intrauterine device, barrier methods, and sterilization.
mm-hmm. Okay. Okay.
Okay, because it does not affect the volume of composition of milk produced by a mother, and no effect on the
Sure.
infant, and don't carry risk of venous thromboemboli.
Mm-hmm,
Like
mm-hmm.
that, the combination with estrogen have risk of venous thromboemboli. Okay.
Yeah, if you have estrogen, but yeah.
Yeah. So, what are the risk factors for endometriosis? These risk factors are
I hate
annoying.
risk.
That's what I
I
hate
hate
about.
risk factors.
Yeah, especially with OB-GYN, it's and confusing, like advanced age, risk factor for so many things. So, what are the risk factors for endometriosis?
Oh my goodness. Risk factors for endometriosis. Sometimes I blank on these risk factors. Endometriosis, not endometrial cancer, right?
So, yeah, it's null parity, early menarche,
Is
shorter.
it is it endometriosis or are you talking about endometrial cancer?
No, endometriosis.
Huh.
Yeah,
Okay.
surprisingly, yeah. And there is a table about it, by the way, yeah.
Interesting. Okay.
Full table, it's very legit table and stuff. That's the first thing written. Null
Huh.
parity, yeah. If you don't have kids, early menarche, if you menstruate earlier, shorter menstrual cycles, menstrual outflow obstruction. Okay. So
Endometriosis, huh?
yeah, endometriosis, yeah. Everything else you know that cause pelvic pain, dysmenorrhea, infertility, and you treat it with,
Mhm.
you do
Mhm.
laparoscopy to diagnose that.
Mhm.
So if you are at
Let me write it
25,
down.
yeah, if you are at
Hold on.
20, huh?
Let me put it down so that I can look into that. Endometriosis. Okay. Go ahead.
So if you're a 25-year-old woman,
Mhm.
unfortunately you just lost a baby, now you have a breast fullness and tenderness. So how can I suppress your lactation here?
Okay, I know they say that breast binding it no longer works. You can do what do you call it? Just NSAIDs. You can do like ibuprofen, things like that. Don't
Yeah,
do
yeah,
breast binding.
yeah, and avoid nipple stimulation.
Yeah.
So if you're a 38-year-old woman
How
with
many?
38-year-old woman,
Okay.
when I examine you, I found 5 cm dilated cervix with firm, round, dark red mass at the os. Boom. So what do you think is your diagnosis?
38-year-old woman. How many weeks gestation? Not pregnant or pregnant?
Yeah, she's so she's having pain like labor and she's having pelvic pain. She's not pregnant.
Oh, like you're talking about endometriosis? I don't know. I'm
What
confused with the
condition you
question.
have? Firm, round, dark red mass at the cervical os, cervical dilated, even though if you're not pregnant.
I don't know.
It's leiomyoma uteri.
Oh, huh.
Makes sense, right?
Hmm. Okay.
Can cause labor-like pain, cervical distension by the solid mass.
Interesting. Okay.
Interesting, right?
Mm-hmm.
It's very. This is a leiomyoma. It's annoying, you know.
It is.
Yeah. Even though I don't have it, and I will never be able to have it. It's annoying.
Yeah, funny.
So what test do you order before trastuzumab?
Oh, you do echo.
Yeah, these are simple. I wanna give hard questions. So if you are a 48
No,
woman,
give me everything, not just hard questions.
okay, everything, yeah, everything. So if you are a 48-year-old woman, when I examined you, I found 1 ml of reddish brown fluid expressed from the right breast only. I think you will know that. What do you think?
Reddish brown fluid,
Yeah, unilateral. Bloody
unilateral.
discharge from the breast. Or
Is it not intraductal?
yeah, papilloma.
Papilloma?
Yeah.
Mm-hmm.
So obviously, if it's bilateral and
Mm-hmm.
serous, okay, then this is normal. Okay, the proactinal more likely. But unilateral is scary. Okay,
Okay.
okay, and you may not find mass or lymphadenopathy, and it's cancer. You know that's a risk factor. That's the
Mm-hmm.
interesting part. So you do mammogram biopsy, excision. Okay, now it's interesting. So if you are a 28-year-old woman who present with nausea, vomiting, epigastric pain, right upper quadrant, okay? That's an important question.
You said a pregnant?
Yeah. And when I check the labs, yeah, I'm gonna give you more clues because so that you know. So when I check, so the blood pressure is 160 over 94, and the protein urea. Now you got the idea what's going on, okay? I'm gonna give you more.
Okay. Okay.
Platelets is 96,000. Total
Mm-hmm.
bilirubin is 2.6.
Mm-hmm.
AST/ALT around 300. What's your
Mm-hmm.
diagnosis?
Something about the capsule, extension of the
Yeah,
capsule.
excellent. Yeah, it's HELP. Yeah.
Yeah,
So
health
this is
syndrome with.
so this is how they tell you. They don't tell you low platelet hemolysis, elevated liver
Mm-hmm.
enzyme, HELP. Okay.
Right.
The H, hemolysis, HELP. H is that they tell you.
Hemolytic.
No, yeah, they don't tell you that. They tell you total bilirubin is 2.6. That's mean hemolysis.
Uh-huh. Okay.
Low platelet, they give you the number of platelet decrease like 1,000. And the elevated liver enzyme, they tell you the AST, ALT 300. Okay. So it's a HELP syndrome, present with eclampsia. Yeah, now I'll ask you something that you will like. So if you have ASCAS, no, those were my nightmare. Like it took me some time to. So if you have ASCAS or low cervical lesion in a 21 to 24-year-old, okay, so if you are a 23-year-old girl with ASCAS,
Mm-hmm.
what should I do now?
Okay, so for 21 to 24, you repeat the pap smear at 12 months because sometimes they can regress. So if you repeat and it's negative, I think you also repeat again at 12 months, right?
Yeah, go ahead.
Yeah, so you repeat at 12 months, negative, you repeat again at 12 months. But if it's, what do you call it, all these other ones, then you have to do colposcopy. If it's positive, you do colposcopy.
Yeah, that's interesting. You repeated in 12 months twice. Okay,
Mm-hmm.
so ASCAS initially, repeat in 12 months. Negative, repeat in 12 months. Negative, routine screening. Okay.
I'm
Okay.
So
sorry, could you repeat that, please, to ask us workup?
yeah, so when you have ASCAS, you repeat pap smear at 12 months, and if it's negative, you repeat it in another 12 months. And if it's negative again the second time, then you do routine screening. If any of these three times that we repeat, if there's abnormal ASCAS like high grade dysplasia, we do colposcopy. Okay? You get the idea?
Mm-hmm.
Sahar, you get the idea? Hello?
Yes, yes, I do. Thanks.
Okay, okay, you're welcome. Yeah. Yeah, so that's the idea for ASCAS, and it's like basically we treat them like HIV. HIV we treat them annually. We treat them HIV like for 2 years, but only.
So this hybrid dysplasia could be the first repeat or the second or the third. If it's positive, then we go ahead and do colposcopy,
Yeah,
right?
yeah, exactly. Anytime it's positive, then it's. Yeah, ASCAS doesn't consider it positive, only if it's high grade dysplasia, then positive.
Oh.
So now, so what? You're a 16-year-old girl who had a sexual intercourse last night and came for emergency contraception. What should I give you?
You are a what?
You're 16-year-old girl with, you came for an emergency contraception. What should I give you?
Okay. I thought we talked about it, like doing
Next step, not the most effective one.
oh, not the most effective one.
Yeah, it's different when
Um,
they say the most effective one. Should be pay attention to the question. If they say most
okay.
effective one,
Mm-hmm. You
then
can
do
do
copper.
the, what do you call it?
But if it's negative,
Mm-hmm.
yeah, just tell them to go to Walmart pharmacy and get a Plan B, levonorgestrel pill.
Levonorgestrel. Okay.
Okay.
So say, can you repeat that again so that I can get the clarification?
Yeah, so if they tell you what's most effective for emergency contraception, you do
Copper
copper.
IUD, okay?
So if they tell you
Mm-hmm.
next step, levonorgestrel.
Okay.
So if you're a 36-year-old woman, when I examined you, I found area of erythema and tenderness in the upper outer quadrant of the right breast. I check your temperature, I find it 101, and you're breastfeeding at the same time. What should I do
Mm-hmm.
for you?
Okay, erythema, not fluctuant mass. Okay, so this will be mastitis. So warm compress and antibiotics, mostly like anything to cover staph, like napsicillin.
Yeah, yeah, exactly. Yeah, you give her
But if it's fluctuant mass, that is abscess, then you have to do incision and drainage, right?
yeah, look at the risk factor. If there's recent
Mm,
antibiotic, if she was in long-term facility incarceration, if any of
mm,
these positive, then you give clindamycin. TMP, SMX, vancomycin. If those negative, then you, like if she's not incarcerated, no risk factor for MRSA, then you give ducloxacillin and Cephalic.
Mm-hmm.
Interesting, right?
Mm-hmm.
Yeah. So what are the risk factors? Your favorite question for that?
For what?
Yeah, trust me. Like I'm not a big fan for risk factors, but they ask about it. That's why.
Risk risk factors for what?
Mastitis.
So risk factors for mastitis, of course, if you're not, breastfeeding, like, emptying out the breasts as you're supposed to do. I know that you're supposed to breastfeed every 2 to 3 hours. So if you're not doing that for the baby, you can get, clogged up of the duct. What else? That's the one that I know.
So previous history of mastitis,
Is
and
number one.
yeah, and the other thing, engorgement or inadequate milk drainage due to
Uh-huh. Yeah, that's
sudden
the one.
increase in sleep duration, replacing nursing with formula or pumped breast milk, weaning from breastfeeding,
Yeah.
pressure on the duct, tight brown clothing, prone sleeping, cracked or
Mhm.
clogged nipple, poor latch.
Whole latch. Okay.
Yeah, that's the thing. Yeah. So most of the
Okay.
time, yeah. Sometimes present
So
to.
bottom line, if you're not emptying the breast,
Yeah,
some,
exactly. Yeah,
yeah.
and you gotta pay attention for if they say just erythema, that's mastitis. But when they say fluctuant nodular, this is abscess.
Abscess.
Yeah, they can have myalgia, chill, malaise, and stuff. Yeah. My mom always tell
Mhm.
me that she breastfed me for 2 years and a half. I never used
Oh
formula.
my goodness.
Yeah.
3 years.
Huh? Yeah, yeah, yeah.
Man, are you
I'm lucky, huh? I was lucky.
you are very lucky. You should be very, very smart.
Yeah, she always tell me I didn't use any formula and stuff.
That's
So
why
you
you're very smart.
should be grateful, huh? No, no, I'm not smart.
You are smart.
No, I'm not. So you treat it with the frequent breastfeeding, pumping, analgesia, and antibiotics.
Okay.
Yeah, so it's hard. Like our mom, like what can we do, like to take care of them, like to give that back, like it's not like buying them a bottle of milk and giving back to them. Like it's not. Like it's something like they cared for us when we were not able to take care of ourselves and we are in weak
Hmm.
condition now. Now we just gotta take care of them back, and it's hard. Like we can't get back to them whatever they sacrifice so much for us. Like no
Of
matter what we
course.
can do, yeah,
Yeah,
it's
I'm
hard.
going to
Yeah.
medical school at old age because of my kids.
Oh,
I should have
really?
been done by now.
Really? Why? Like,
Because, I was home I have 4 boys, so I was home having children.
yes. So you went to school because
Yeah.
of them? Wow, that's cool.
No, I did not finish on time because of
Oh,
them.
oh, I
Yeah.
see, I see. Yeah.
Yeah.
So, wow. So when did you start?
When did I start?
Yeah?
4 years ago.
Oh, I see. Yeah,
Yeah.
wow. Yeah, you see, they
Yeah.
sacrifice a lot, and then
Yep.
some of them, they may not be grateful. Yeah,
Mine, they better be.
I hope so. Yeah, yeah.
All right.
So if you are a 34-year-old woman,
Mm-hmm.
when I examined you, I found multiple small teardrop-shaped growth at the vestibule of the vulva.
Multiple
Yeah, teardrop-shaped growth.
teardrop shaped growths.
Yeah, so what do you think is causing this issue? How should I treat it?
Teardrop shaped. Any other description like
Okay,
vesicles, ulceration, nothing.
I'll give you another big clue. When I gave trichloroacetic acid, there's complete resolution of the lesion. What is it? What's the
Or
diagnosis?
HPV.
Yeah, yeah, obviously. Yeah.
HPV.
So if you're a 62-year-old woman with right adnexal enlargement on ultrasound, when I did transvaginal ultrasound, I found 5 cm unilocular right ovarian mass with regular borders. So what should I do next? It's scary, right, to have a 5 cm mass in your ovary, right? So what should you do?
Mm-hmm. Okay, so you already did a transvaginal ultrasound, right?
Right.
And then the transvaginal ultrasound is showing this.
Yep.
Okay, so of course you're not gonna do, you don't do a biopsy because they said it can cause seeding.
Yeah, we do cancer antigen 125.
Mm-hmm.
Okay, that's the thing.
You don't do biopsy, right? Because you don't want it to cause seeding, right? Seeding
Excellent.
of
Yeah,
the,
yeah, yeah. Never,
okay,
never biopsy ovary or
okay.
testis. Be careful.
CA 125.
Yeah. So if you're a 33-year-old female with brownish gray discharge from both nipples, what should I do next?
Check for prolactin.
And TSH
Huh?
plus TSH.
Plus TSH, okay.
Because remember, hypothyroidism can cause
Right. Mm-hmm.
hyperprolactinemia.
Yes, yes.
Okay. So if it is, so you check, so you look at the color of discharge. So this is how you evaluate nipple discharge. If it's unilateral, then you do ultrasound mammogram. Or
Mm-hmm.
if it's a bloody or serous, the same. Okay. But if none of that and it's milky, non-bloody, you look if there is any palpable lump or skin changes. If there is any, then ultrasound and mammogram. Okay, so remember three things. If it's unilateral, if it's bloody, or if it's
Mm-hmm.
milky, or if it's a palpable pump. Okay, that's third. If any of these, then you do ultrasound, mammogram, phase more than 30. If
Mm-hmm.
it's none of that, likely physiologic. So what you do, pregnancy test. You can do
Mm-hmm.
GAIAC test, which is to detect blood in the discharge, prolactin,
Mm-hmm.
TSH.
Mm-hmm.
Okay, and consider MRI if the prolactin is super high.
Okay.
So now this is a very important case. So if you are a 23-year-old girl who had a sexual intercourse, but after that you developed severe pelvic pain, I do ultrasound on you. I found 5 cm right cystic ovarian mass with moderate amount of free fluid. Doppler velocity of the ovary is normal. What do you think is
It's
going?
normal.
Yeah,
Okay.
yeah.
Okay. Rupture of the cyst, ovarian cyst.
Excellent. So that's the biggest clue for
Mm-hmm.
the rupture ovarian
Ovarian
cyst.
torsion. Mm-hmm.
Okay. And torsion, they have decreased Doppler velocity, blood, and it's like when it's after sex, more likely cyst rupture.
Mm-hmm.
Probably
And
did some.
torsion also if you have nausea, vomiting, right? Nausea,
Right,
vomiting.
right, right.
Okay.
So
Could you
for
repeat the clue again for the cyst rupture?
yeah, so Doppler velocity, that's the main thing. If the Doppler
That was
velocity
increased?
is normal, that's a cyst rupture. If it's
Okay.
decreased, that's a cyst rupture, ovarian torsion.
Okay.
Okay. So when you have acute abdominal pelvic pain in women, it could be either Mittelschmerz, it could be ectopic, could be ovarian torsion, could be ruptured ovarian cyst, could be PID. Go ahead, tell me what's the difference between both.
Okay. So middle Schmiss or something like that will be mostly around the middle of the menstrual cycle,
Yeah, it
right?
lasts a few hours to a couple of days.
Okay.
But we don't need to do ultrasound in this patient, just reassure, okay? So to be careful.
Right.
Yeah, for
Then for
ectopic
which
pregnancy.
one? Ectopic pregnancy, you can have like a amenorrhea. Sometimes you can have like pregnancy. They will say that menstrual period last was, more than 4 or 5 weeks ago. And then some vaginal bleeding, and then that abdominal pain,
Yeah,
you know.
amenorrhea,
Yeah,
abdominal pain, vaginal bleeding, positive HCG.
right. And then if you see that something free fluid, it can be rupture, ectopic rupture,
Yeah.
and then they will also have hypotension, all that, vital signs, instability if it's ectopic rupture. Then, just like what you said about ovarian cyst and ovarian torsion, the difference is basically when you do the ultrasound, if there is a normal Doppler flow and decreased Doppler flow. Ovarian torsion will have decreased Doppler flow plus nausea and vomiting. Ovarian cyst, regular ovarian cyst will be the lower abdominal pain. And if you do the Doppler ultrasound, it will be normal.
No, you will have a
Also,
free fluid near ovarian cyst on ultrasound with the
no, I'm
rupture.
just saying cyst, not the rupture.
Oh,
Just
yeah,
regular
yeah,
cyst.
yeah,
Yeah,
yeah, that's true, yeah.
yeah.
And the difference between ruptured ovarian cyst, so ruptured and ovarian torsion, both are present with severe unilateral lower abdomen pain with nausea and vomiting. The
Mhm.
difference in clinical, ovarian ruptured after strenuous activity or sexual activity. Ovarian
Okay,
torsion, unilateral or tender adnexal mass, you can have that torsion.
okay.
The
Do you
ultrasound, huh?
also, okay,
Yeah, yeah,
go
go ahead.
ahead, go ahead. I'll ask later.
Ultrasound, you have enlarged ovary with decreased blood flow, but you have free fluid on the ruptured cyst, but
Okay,
decreased flow on the torsion. Okay.
okay.
PID, present with fever, chills, vaginal discharge, lower abdominal pain, cervical motion tenderness. That's a big one for PID.
Mm-hmm.
And on ultrasound, you may or may not find an abscess. That's the difference. So,
In
what was your
PID,
question? Yeah.
would they give you like a history of like a STD, things like that
Yeah, but
for the
even
PID?
yeah, even if they don't give, it's very easy to pick it up. Fever,
Mhm.
vaginal discharge, cervical motion tenderness. Yeah.
Okay. Then another question is, those when they rupture, will you get like in the question stem something about radiation, like to the shoulder or things like that, like pain radiation
You mean radiation
or
causing
not?
cyst rupture?
Sometimes they do, sometimes they don't, right?
You mean radiation causes
Like
cyst rupture?
peritonitis, signs of peritonitis. When you have that fluid,
Yeah.
something in the peritoneum, you have peritonitis, and then sometimes I remember one question where they gave you like a radiation to the shoulder because of the fluid in the abdomen due to peritonitis, and they said
Yeah, they
radiation to the
three. So it's just like ectopic pregnancy. You have three signs: amenorrhea, pelvic pain, and vaginal bleeding. For peritonitis, you have three signs, which is rebound, guarding, and rigidity. Or they tell you the pain lies motionless from the pain and guarded, rebound, tenderness. Those are the three very important signs for peritonitis. If they don't give you those, it's less likely to be.
that could be appendicitis, right?
Yeah, could be. Yeah, RGR, rebound, guarding, rigidity. Okay, so now what are the greatest risk due to tamoxifen? What are the side effects of tamoxifen?
So you can have what do you call it? Hot flashes, headache, DBT. What else? At least those three: headache, flushing, DBT.
Endometrial hyperplasia and cancer, that's the biggest one.
Yes, 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 yes.
When do we use raloxifene versus tamoxifen?
So tamoxifen will be um, agonist at breast. So you use it to treat breast cancer, and it can cause endometrial cancer.
Yeah,
So that will be antagonist at the endometrium.
yeah, and the
And it's also
uh-huh.
agonist at bone. Yeah, the laroxifene is for osteoporosis. Yeah.
Perfect, yeah, postmenopausal osteoporosis. So if you are a 25-year-old girl with abdominal bloating, headache, fatigue, weight gain, and anxiety, decreased libido, and you experience these symptoms in 7 to 10 day episodes, and you're unable to identify a trigger for those symptoms. What do you think is causing that issue?
Okay, say it one more time. Let me see if what you're saying is what I'm thinking.
Abdominal bloating, headache, fatigue, weight gain, and anxiety, decreased libido.
I don't understand that question, but go ahead.
This is called premenstrual syndrome.
Mm.
Okay, that's how they describe it. Present with fatigue, weight gain, and anxiety, and decreased libido, like every 10 to 7 days. That's how they describe it. So be careful for that. Like,
When you
so-
say every 7 to 10 days, is it after menstrual period or?
they don't tell you. Like even the question stem, they just tell you occur intermittently in 7 to 10 day episode. That's mean they occur and go and occur and go. That's mean every before premenses. They don't. You know how the question. They don't tell you like it's that clear before premenses. So this is how they describe it, intermittently. When they give you their symptoms, most likely premenstrual syndrome.
Okay.
Yeah, you know a lot of girls have that mood swings and stuff every time.
A lot of girls, the ones you know.
Huh? Yeah, the ones I know at least. Yeah. So yeah, and this one increased risk for depression, by the way. They ask about that too.
Okay.
So if you are a 41-year-old nulliparous woman who present due to loss of urine with coughing. So, and when I examine you, I found irregularly enlarged uterus. What should I do?
Ultrasound.
Yeah, ultrasound.
Myoma.
Yeah, that's an easy question, you know. It's very simple, even. Okay, so now if you are a 22-year-old professional tennis player who did not have menses, okay? So if you want to play tennis, tennis, you can't have menses, like you can only get one. Either tennis or menace. Tennis or menace. So the LH, FSH are low, prolactin is normal, no menstrual bleeding after 10-day challenge of medroxyprogesterone acetate. So what's your at greatest risk? What's going on here? What's the diagnosis and what's the risk factor?
Is it not hypogonadism, affecting the HPA axis?
Yeah, what are the complications?
So, of course, infertility is one. Osteoporosis is two.
Yeah, that's the thing, yeah.
Those
It's kind of hard, like it's unfair for girls, like if they play sports and stuff, they get these, they be infertile and they have osteoporosis, right? It's hard, I don't know why. I feel bad. Yeah, so
I know.
yeah. So this is functional hypothalamic amenorrhea. When you have excess physical training, very low calorie diet, starvation, weight loss, chronic illness, stress, depression, anorexia nervosa. All of those can increase hormone, which is ghrelin, the hunger hormone, NPI, CRH, GABA, beta endorphin, and decreases leptin, which comes from the fat. So when all of those increase, causes hypothalamic suppression and decrease GnRH. When the GnRH decrease, what do you expect will happen to the LH and FSH?
Low.
How about the estrogen?
Estrogen will be low too.
So that's why you will have amenorrhea, low estrogenic state, bone loss. Yeah, it's unfair, right? Like
I know.
Yeah, I don't know. Could you maybe change it or something? I don't know. Could you? No, I'm joking.
You can. Huh? You're getting in the medical field. You can.
Really? How could you change it?
I remember one thing that I read is, if they want to get pregnant, you can help them by doing like IVF induction.
Oh, wow.
Yeah.
Yeah. I think also you
Like
can give
all
them.
those,
Yeah, I think if you give them pulsatile GnRH,
right,
they
yeah,
will be perfect. Yeah.
they
Yeah.
can be skinny, then if they want to have babies, of course they can get pregnant on their own. You can do like a, ovulation induction,
That's
giving
true.
them all those.
Yeah. Yeah. Last time I saw like there was an like Italian girl. She was like a boxer and she's a bodybuilder. Like it's crazy. Like it's feel like I think she will beat me and like 10 guys like me. I feel made me feel bad about myself. Like these exams like it's crazy. Like you don't have time to do. Hopefully will be done.
You don't have time to exercise.
Yeah, like even when you exercise, you don't have time to spend too much time. Like I count my time in the gym. Like I just say 20 minutes, 30 minutes.
Yeah.
That's and sometimes I listen to lectures while I'm in the gym. Yeah. So this patient, what are the greatest risk factor to decrease breast cancer?
Or to decrease breast
Yeah.
cancer.
If you decrease alcohol, you'll decrease risk
Oh,
for. This is modifiable,
okay.
and there are non-modifiable risk factor for breast cancer. For example, hormone replacement therapy, genetic mutation, or breast cancer in first degree
Mhm.
relative, white race, increasing age, early menarche, late menopause. You can't change all of those. You can't change any of them. I guess maybe which. No, yeah, you can't change any of these. Yeah. Genetic, yeah, I mean, nobody can stop age, nobody can change race, nobody can change genes.
Yep.
Hormones already have hormones, yeah, it's tough, there's stuff you don't. Okay, so if you are 42-year-old woman who change tampon every hour, when I examine your uterus, I found soft, tender uterus. Go ahead, what's your diagnosis?
You change tampon every.
Hour.
Okay.
Soft,
And
tender,
then
and painful menses with tender uterus.
performances. You're talking about endometriosis?
So this most likely when you have heavy menses, it's most likely adenomyosis.
Oh, okay. Yeah. Yeah, that's true.
Yeah. So it's
Mm-hmm.
totally
Yeah, that
fine.
one is painful. Yes. And regular.
So they will have uniformly enlarged uterus.
Mm-hmm.
So if you're a 47-year-old, when I examine you, I found uterus is boggy, tender, globular, and freely mobile. What's your diagnosis?
Okay, you're breaking out. You're breaking.
Hello, can you hear me?
Okay.
Yeah, so how do you differentiate adenomyosis from fibroid and endometriosis?
Okay. Oh, and endometriosis. Okay, let me do between um, fibroid and adenomyosis. So for fibroid, it's going to be firm, irregular, contour, uterus. Okay. Adenomyosis is going to be soft, globular, boggy, uterus. For endometriosis, it's going to be immobile, uterus. And then for fibroid, less. Mysis is going to be painful, and the endometriosis is going to be painful, something like that. What else?
Yeah,
And then endometriosis has all this other one, the dysmenorrhea, this pain with sex, pain with urination, pain with defecation.
yeah, and fibroid can have heavy menses, constipation, urinary frequency, pelvic pain,
Right, urinary
heaviness.
pref.
Yeah, that's
Mm-hmm.
the thing. So if you're a 36-year-old African American female, when I examine you, I found mass to be non-tender, mobile uterus with several protuberance. What's your diagnosis?
Yeah,
Several,
African American. Yeah,
yeah,
several.
protuberance on the abdominal examination. What does that tell you?
Leiomyoma.
Yeah, perfect. Yeah, I like that you're really good at differential diagnosis. You're good at. That's what they want in the exam. Like you gotta be able to know them, differential diagnosis, from the minimum amount of information. So now, that's what I'm gonna tell you. If you're a 25-year-old female at 8-week gestation, your previous pregnancy have placental abruption at the time of the delivery, and you received NTD immunoglobulin at 28 week
Mm-hmm.
and 1 day postpartum in the previous pregnancy. Now I check your antibody titer is 1 to 32. So what explain this finding?
I think because they didn't give enough what do you call it? Enough Rogam at the previous pregnancy.
So how do you tell if it's an enough or not?
Because I think you do that what do you call the Klauer-Bettkis test. Bet. Okay, let me go back. So this present pregnancy, the titer is 1/32, right?
Yeah, so 1 to 32, what does that tell you?
So what it tells me that is, the mother is what do you call it? Has a lot of antibodies to the anti-Rh negative
Yeah, that means
in
she's
her system.
sensitized
Yeah,
and stuff. Yeah,
yeah,
okay.
she's sensitized. Yeah. Mm-hmm.
Okay, so yeah, so what is the standard? So the standard dose is 300 at 28.
Mm-hmm. Mm-hmm.
Okay. However, 50% of Rh negative women will need a higher dose after delivery when there is a placental abruption or procedures. So that's why they
Okay.
do clear Petic test to
Mm-hmm.
determine the dose. So they put the red blood cells on maternal circulation, are fixed on a slide, and the slide exposed to acidic solution. So all the adult hemoglobin lies, leaving only the ghost cells. The dose of NTD immunoglobulin is calculated from the percentage of the remaining fetal hemoglobin. Okay, so it's very interesting mechanism.
Okay.
Okay, so you're right. There was no adequate dose that's given.
Mm-hmm. Post delivery.
Yeah. Cool. I think we're about to finish the OB-GYN. So I think okay. So if you are taking metronidazole, you have pear-shaped due to pear-shaped motile organism. What should you counsel the patient on?
So the partner should be treated also.
Yeah, on no alcohol too.
Okay.
Okay, yeah. So if that's that if you have UTI in a pregnancy, you treat it with nitrofurantoin, amoxicillin, amoxiclav, and you never give fluoroquinolone, TMP-SMX, or tetracycline. Huh? If you have a UTI in a
You were
pregnancy,
so fast.
oh sorry, yeah. So if you have a UTI in a pregnancy, you give amoxicillin and try to avoid the tetracycline and TMP-SMX. Okay, because you want to avoid the drugs that can you want to avoid the drug that can affect the fetus.
Right.
Okay, yeah. So now, if you are a 25-year-old woman at a 37-week gestation and you have a cluster of clear vesicle on the right labia minora, so how should
Uh-huh.
I treat you?
So you're not gonna have a vaginal delivery, you're gonna have C-section.
C-section. So I'm gonna ask you the question, your lovely question. What are the risk factor for neonatal herpes simplex virus infection?
Risk factors for HSV,
Yeah,
neonatal in the baby.
yeah.
In the baby. So of course, from the mom, all these risk factors to me sometimes they don't mean anything. I don't know. Is it not getting it from the vertical transmission from the mom?
Yeah.
What else?
So there are maternal infection, primary maternal infection, like this patient, or longer duration of the rupture of membrane,
Mm-hmm.
vaginal delivery with active lesion. That's the thing. and then impaired skin barrier like fetal scalp electrode or preterm birth.
Okay. Mm.
So if you have any of those, your risk for herpes simplex virus infection.
Increases.
Okay. So if you are a 24-year-old girl at a 36-week gestation, your temperature is 101. By manual exam shows tender uterus and foul smelling leukia.
Mm-hmm.
So what's your diagnosis?
Choreo,
Huh?
choreo, amnionitis,
What is if it's postpartum, like you just delivered the
or
baby?
postpartum endometritis.
Excellent, excellent, yeah. How do you treat endometritis?
ECG, clindamycin and gentamicin.
What is ECG?
E for endometritis, C for clindamycin, G for gentamicin, ECG.
ECG, I like that, yeah. Clinda, I like that, yeah, that's a good one.
Mhm.
So if you're a 27-year-old female who came to the emergency department at a 10-week gestation with vaginal bleeding and crampy lower abdominal pain. When I examined you, I found effaced dilated cervix with gestational tissues visualized through the internal cervical os and with vaginal bleeding. And the cervix is dilated. What type of abortion is that?
Incomplete.
And the fetal heart, there's nothing out, nothing came out, and the fetal heart rate is still there.
Oh, that's the one. What do you call it? It's not complete. It's the other one.
Inevitable?
Inevitable.
Excellent,
Yes.
yeah. It's an inevitable. When you have abdominal pain, vaginal bleeding, a face dilated cervix, that's an inevitable abortion.
So tell me again, how do you differentiate between incomplete and inevitable?
So incomplete, they tell you that there is some part of the fetus passed out.
Okay.
Okay, that's how they describe it.
Mm-hmm. But inevitable, sometimes you have the baby is still in the gestational sac, right?
Yeah.
Or the
Inevitable.
fetus.
Yeah.
Okay.
But because it's dilated cervix, inevitable. If it was closed cervix, then it's threatened. It's the same thing, threatened.
Mm-hmm.
If they tell you everything passed out, empty vaginal, if empty uterus, then complete. If they tell you no heartbeat and the baby is still inside and the cervix is closed, then that's missed abortion. Okay? You get the idea?
Yes.
Okay. Yeah, now the question you like is that how to prevent neonatal GPS infection. So when do you give GPS infection?
GPS, when do you give a GBS?
Prophylaxis, yeah, when do you give penicillin?
Okay, so you do it if they have like a prolonged rupture. Okay, then if they have what do you call it? Preterm, if the status is unknown, right? Those three, and then okay. Also, if they have a history of a baby with GBS infection.
Yeah, so you gotta remember three things and the fourth thing, okay? The three things, number one, a prior baby with GBS infection. Second thing, GBS bacteriuria or GBS urinary tract infection anytime during a pregnancy, regardless of the treatment. The third one, GPS positive in 5 weeks of labor at 35 to 37 week gestation, okay? Those 1, 2, 3, okay? Now I want you to pay attention to the number 4 because it's the most difficult one. If the GPS status unknown and she's in delivery, then you need one more thing, which is the less than 37 week gestation or intrapartum fever or rupture of amniotic membrane more than 18 hours.
If you don't mind, can you type it when you finish so that I can put it down and go through it?
Yeah, so if it's unknown, you need two things. If it's less than 37,
Okay, hold on.
weak
Let me write
gestation,
it. So GBS,
intrapartum fever.
the, are you typing it or you want
Yeah.
me to write it down?
Rupture of amniotic membrane for more than 18 hours. Okay. Others, this is if it's unknown. Okay. Others, you can have a prior GPS baby, like GPS sepsis baby, and GPS infection anytime during pregnancy. And what is the third thing?
So GPS infection anytime during the pregnancy, prior GBS baby. And the third one is, hold on, don't tell me.
GPS positive in 5 weeks before labor.
GPS, okay.
Okay.
That's at 35 to 37 weeks.
Yeah, 35 to 37 weeks.
Okay.
Okay, so what are the indications for cell-free DNA testing?
Oh, wow. Cell-free DNA, that's the one you do at 10 weeks, right?
Yeah, but what are the indications? Like, these are the indications for GPS testing.
Okay, I remember you said something about mom being mom age greater than 35, right? And
Yeah.
what do you call it? So mom age greater than 35. Also, if there is if you want to rule out, is it aneuploidy or chromosomal abnormality? What else? Those are the two that I remembered.
Yeah, if there's mom more than 35, okay, let me write it down. I can write it down because this is important and you tend to forget it easily.
Yeah.
DNA testing. Number one, mom more than 35. Second thing,
Are you sending the text to me? I'm not receiving
I can
the one.
send. No, I'm.
Oh, later.
Do you
Okay.
see my screen? Am I sharing my screen?
No, you're not.
I'm writing. I thought you guys see my screen. Okay,
I'm not
yeah.
seeing it.
I'm gonna send it to you. Yeah. Abnormal serum screen. Mom's serum screen. Sonographic. I'm gonna send it to you.
Okay.
Finding associated with aneuploidy.
Mm-hmm.
Previous pregnancy with fetal aneuploidy.
Mm-hmm.
And Robertsonian translocation in the parent. Okay. Because if you
In
have
the
a
parents.
Robertsonian translocation, it's just like your same risk as being more than 35. You're at high risk of being having Down syndrome. And so the other thing, you can be used for trisomy 2118 and used for fetal sex determination. Did you use it to determine the sex of your babies?
No.
Really? Why? So when do you know? How do you use?
And I didn't do anything.
Oh, so you don't know till for 9 months?
Oh no, they told me normally I think from 4 months or something like that. Yeah, I asked.
Oh, 4 months?
Yeah.
That's cool.
Mm-hmm.
And you have how many boys, how many girls?
I had just have 4 boys, no girls.
Oh, 4 boys? Wow,
Mm-hmm.
that's cool. That's nice, yeah. Yeah, so now when Okay, so those are the indications for cell-free DNA testing. Okay, so what are...
Okay, let me see if I can remember what you said. Okay, if maternal age is greater than 35, if mom has abnormal screening, port screen or any of those screening, if previous pregnancy has baby with aneuploidy, and then you said Robotusonian translocation in the parent, in one of the parents.
Yeah, exactly, yeah. So
Okay.
now it's an important one. How do you treat postpartum atony, and what are the risk factors for that?
So postpartum atony, first of all, you do massage, and then you can do the what do you call it, oxytocin, or you can do the is it metagovonin or something like
Yeah,
that?
methyl-ergonovine, yeah, good job, yeah. Carboprost or
Or
misoprostol.
yes, carboprostol, yeah.
So
And
how
then
do
a
you... Yeah, risk factors, yeah, go ahead.
risk factor for uterine or prolonged labor,
Okay.
polyhydramnios, multiple gestation. I think those three. I always try to know 2 or 3, and the other ones, my brain just
Retained placenta and chorioamnionitis.
retained placenta,
And
chorioamnionitis.
chorioamnionitis too.
Okay, all right.
Yeah, but good job, like that you remember these risk factors. They're annoying. So what are the contraindications for external cephalic version?
External cephalic version, if they are having like a action right, of course you don't want to do it. If they have placenta previa or placenta abrupto or chorioamnionitis. What else? Yeah, at least I named 4. Yeah. Or I guess if they are not up to like 37 weeks, you can do that. So if they're not up to 37 weeks, if they have choreo infection, if they have placenta previa, placenta abrupto, any contraindication for like, vaginal delivery will also be like a contraindication for
Yeah,
external cephalic.
yeah, that's true. Yeah, yeah. So whenever you have any indication for C-section, like failure to progress during labor, or if you have oligohydramnion, ruptured membrane, hyperextended fetal
Okay.
head, fetal or uterine anomaly, multiple gestation, any of that, you're high risk of bleeding. So that's why you don't do external cephalic version in this case.
Okay.
Okay, so that's the thing. So what are the pregnancy-related risk? That's a crazy question and it's annoying. So what are the risks due to hypertension?
Okay, so risk due to hypertension, of course, would be small for gestational. Oh, you do want it in maternal and in fetal. I don't know. I remember you. Okay, so for the baby will be small for gestational age, so the baby will be small. Also, you can have a like because of the hypertension. That will be for mom. Also, there will be so preeclampsia, small for gestational age for the baby. Yeah, that asymmetric growth, which will be small for gestational age. What do you call it? Yeah, I don't know. Those are the
Yeah,
ones
there
that
are
I.
maternal issues, which is superimposed preeclampsia can
Mm-hmm,
cause
mm-hmm,
postpartum hemorrhage. You know, it's
mm-hmm,
crazy. Sometimes they just have hypertension, and they give you like a 10-line case, and the only abnormal is hypertension. Okay, and they make you read it, and then they tell you
mm-hmm,
risk factor associated with this condition. Okay, and you
mm-hmm,
gotta just pay attention. They give you the blood pressure 145 or so, and
mm-hmm.
they throw one of these. So hypertension causes diabetes. Can you imagine gestational diabetes?
Right.
Increased
Yeah.
risk for
Mm-hmm,
apresoplasty, C delivery, postpartum
mm-hmm.
hemorrhage. Preeclampsia. So it makes sense. Increased risk for preeclampsia, hemorrhage, aproptioplasty, and C-section.
Right.
But diabetes, gestational diabetes doesn't make sense. But you gotta remember that. And the fetal
Right.
contraindication can cause fetal growth restriction. That makes
Mhm.
sense. Preterm
Mhm.
delivery, that doesn't make sense. Okay, oligohydramnios maybe because of decreased blood flow. Perinatal mortality can
To the
cause.
placenta. Okay.
Yeah. Perinatal mortality. That's the thing.
Okay. So let me see. So for the baby, will be small for gestational age. What else did you say again? My brain is kind of like fried right now. Um,
Yeah, so it increases oligohydramnios, preterm labor. Yeah, and
I'm trying to memorize it and not to write it down because if I write it, I don't even think I'll go back.
that's true. That's me too. Yeah, I don't go. Yeah. So let's do a rapid recap of whatever we did, like in a short time, like we just do. Okay, so we said if you have heart failure with arterial with sore throat, that's most likely mitral stenosis. Okay.
Mhm.
If you are obese, you will have low menopause. Okay, so before menopause, make sure you eat a lot of food and stuff. So if you because of the estrogen from adipose tissue. So secondary amenorrhea, you do prolactin. Uh, the the benefits, so the combination of contraceptive, the side effect of contraception can cause hypertension and
Mhm.
thrombi.
Mhm.
Okay. If you are obese, you can have anovulation, obesity anovulation syndrome.
Mhm.
We treat vaginismus by dilator and Kegel exercise.
Mhm.
If you have copious white yellow discharge in the vagina, that's a normal, like a physiologic.
Mhm.
Okay. PCOS infertility, we treat it by clomiphene citrate. Most effective contraceptive, copper. Okay.
Mhm.
The risk factor for ovarian cancer is BRCA2. That's main thing. Cervical screening,
Brackets.
yeah, cervical screening for HIV every 6 months for 2 years and every 1 year after. If you have thin dry vagina, white, you do biopsy. Because like in sclerosis, if you have a history of infection and you're infertile, we do hysterosalpingogram.
Mhm.
HCG preserve corpus luteum in a pregnancy. Uh, if you are breastfeeding, you need to give you progestin only pill. Okay, that's the thing. If you have to suppress your lactation, we can give you non-steroidal anti-inflammatory drug and stuff. If you have dark round mass in the ovary, in the vagina, okay, that's a leiomyoma uteri, and labor-like contraction, leiomyoma uteri. We do echo before trastuzumab. Okay, if you have unilateral bloody nipple discharge, that's papilloma. If you have elevated liver enzyme with bilirubin and decreased platelet, that's in a pregnancy, that's HELP syndrome. If you have ASCAS, I repeat it in 1 year. If negative, I repeat it in another year. If negative, then I'll continue regular screening. Lactational mastitis, I treat with dicloxacillin. If you have tear-shaped drop in the vulva, I'll give this most likely HPV. If you have ovarian cancer and you're 60 years old, I'll do CA125. Okay, if you have a bilateral nipple discharge, I'll check prolactin and TSH. If you have abdominal pain, free fluid, and ultrasound after sex, that's cyst rupture. Tamoxifen can cause a breast cancer. If you have anxiety and bloating, that's most likely premenstrual disorder, especially if it's occurring intermittently. If you have irregularly enlarged uterus, that we do ultrasound because it could be leiomyoma uteri. If you play tennis a lot, you may not have menses. white race and increasing age risk factor for breast cancer. If you have tender uterus and you change tampon every hour, that's most likely adenomyosis. And you'll have uniformly enlarged uterus. If you have several protuberance on the abdomen, that's a leiomyoma. If you have the antibody screen 1 to 32, that's most likely inadequate ROGAM in the first pregnancy. We counsel for alcohol, for metronidazole. And the risk factor for herpes neonatal infection, it's preterm birth, impaired skin barrier, fetal scalp electrode, longer duration of rupture of membrane, prior maternal infection, and vaginal delivery with active infection. Period. Boom. And that's a summary of what we reviewed today, like some of the stuff that we reviewed. Okay, do you have any questions, concerns?
No.
Okay, cool. So I'll see you tomorrow. Now we're done with the OBGYN.
Okay.
Okay, so we'll see you tomorrow to start with the...
Tomorrow, actually, we can start at 2.
Okay, 2. We can start
That's
2.
okay.
Okay.
Yeah, 2 is fine.
Yeah, I'm gonna try to do the hard topics, like we do cardio and stuff like that. Okay, good questions.
Ooh, cardio.
Be prepared.
I
Okay.
hate cardio.
Okay. Also, see you guys tomorrow then. Okay.
Okay.
Bye.
All right. Thank you, Dr. Ali.
You're welcome, Dr. Gamanda. See ya. Bye.
Bye.
Bye.